Ready?
And good morning or good afternoon, depending on where you happen to be in the United States and other countries. My name is Mark Perino. I serve as the president of the American Association for the Treatment of Opioid Dependence. With our 29 state organizations, we represent more than 1,400 opioid treatment programs throughout the United States. And this is our opportunity to talk about the SAMHSA regulations, what the treatment providers and other states need to know at the present time. This is supported through the Opioid Response Network from the American Academy of Addiction Psychiatry. And this is a SAMHSA funded grant, and the Opioid Response Network works constantly to assist states, organizations, and individuals through providing the resources, technical assistance they need locally to address the opioid crisis and stimulant use. They've expanded their mission over the years. Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorders and stimulant use disorders. And you can see the funding and the grant specific number from the Substance Abuse and Mental Health Services Administration. And so that brings us into the fact that the ORN provides local and experienced consultants in prevention, treatment, and recovery to communities and organizations to help address the opioid crisis and stimulant use. And the ORN accepts requests for education and training. And each state and territory has a designated team led by a regional technology transfer specialist who's an expert in implementing the specific evidence-based practices. And that brings us now to what the purpose is of our webinar. So there's going to be a survey at the end, but we hold our questions till the end of the three presentations. So today we do have three presenters. We're going to start with Dr. Patty Giuliano, who is the director of the Division of Pharmacologic Therapies in CSAT and SAMHSA. And Dr. Giuliana is going to cover a broad territory of policy-related issues. And she's going to talk about the early response to how the programs and states did respond. And then that'll be followed by Jessica Jennings, the Chief Program Officer for the Ohio Department of Behavioral Health. Jessica's going to be the first to talk about the Ohio state response, including how the providers have responded to the regulations as well. And then finally, Jessica Blouse of the Washington State Opioid Treatment Authority, the SOTA, who's presented at a webinar in the past. And she's going to talk about how the state and the providers have responded to the regulations. And I can say, just as my general reference point, is that the SAMHSA group did a very good job of preparing the field in rolling out the regulations. They consulted with numerous stakeholders and they listened as well. And the regulations, as a result, are well thought through, and there have been extremely favorable responses. Now, I know that Patty's going to talk about them, but I have been surprised in a good way when programs did increase the initial methadone dose from 30 milligrams to 50 milligrams, that did result in increased retention and treatment during the early induction period. And certainly the provision of additional take-homes, which started under the emergency rules of COVID, have increased patient retention throughout the treatment process. And as most people know, retention and treatment is a mark of positive progress because patients, as they are retained, tend to do much better. And that's just the reality. So you're going to certainly get a fair amount of information over the next hour or so. And it is my hope that you find this to be of use. Now, there are a couple of comments that I'd like to make before I introduce Patty. The first point is that it's important for programs to be sure that their operating hours are helpful to the patients. And the key to this is if patients are getting to the programs and the time is sufficient to accommodate the patients that are in treatment. And I underscore that because sometimes that has not been the case. Sometimes programs are operating in restricted hours, and that might limit the number of patients getting into treatment. So the programs certainly should be paying attention to that. Next is all of the programs should have active emergency contact information for the times that the programs are closed. This is also very important. So I have been advised that there are some programs in the country that do not have active emergency contact systems in place. For those who don't, please review this following the webinar and to just check to be sure, because we do want our patients to be able to contact the programs when the programs do close their operations. And speaking of closed operations, I think some programs may have misinterpreted the SAMHSA regulations with regard to take-home capabilities. Programs should not be closing on the weekends. Now, I understand some programs are doing that because they're interpreting as we don't need to have the patients in on Saturdays or Sundays because we're going to give them take-home medication for Fridays. We should not be doing that. And I'm cautioning programs really to reconsider that for those who are, because the programs do need to provide access to care because not everybody is going to be stable enough to do that. So please keep that in mind. Closing on a Sunday or a holiday is one thing that does carry some potential risk. Closing on the weekends is a bit too risky. So just to be clear. And then finally, there's still some confusion as I talk to programs and states about counseling. Counseling is still required. The SAMHSA regulations are pretty clear on that. And while I'm not Patty, I'm not a SAMHSA official, I can say to you that, the key is you don't want to basically hold the medication over the heads of the patient in counseling. You have to engage the patient for sure. But to suggest that while counseling is no longer a required part of treatment is not the case. And for those programs that think it is, or states, I caution you again, because when Medicaid or Medicare conducts its audits, which they do, if the required services aren't provided, programs are going to get hit with very severe penalties. So I advise programs to be very careful about this. This is not a theoretical concept. And, again, I'll say, as I've said in the past, you want to be sure that the individual providing the counseling services know what they're doing. Now, if the counselor is not competent or not engaging with the patient, then that's something for the program director or administrator to deal with. So those are my admonitions. Again, please pay attention to those issues. I just don't want the programs to be either at risk or have these things to come back and haunt the programs as we go on. But again, from my point of view, the regulations are sound, very well thought through, and I've expressed my, congratulations to Patty and her associates since these regulations were fully implemented in October of 2024. So with that, it is my great pleasure to introduce Dr. Patty Juliana, who will be talking about the issues of adherence and alignment and how our field has progressed since the regulations were released. So Patty, thanks for joining us, and please continue.
Thank you, Mark, for this opportunity, and welcome everyone to this presentation. And I do need to turn your expression of gratitude back to those who are present, because this was truly a collaborative effort with significant input from patient, peer group, OTPs, SOTAs, and the like throughout the field. It was really a very rewarding experience to have that level of collaboration. So it's been now almost more than 2 years since the regulations were announced, and April 1 was the kickoff for implementation at compliance date of October of 24. And some of the points that you made, Mark, were important because I mean, they were all important, but they were particularly important because you stressed two of the things that have been a little bit harder for some to uptake the changes. The fact about medication not being used as a tool to gain patient participation in counseling, that counseling is still required, and also inadvertent backwards way, the importance of operating hours being fitting for the patients speaks to the shared decision making and patient centeredness aspects of the regulations. And the reason I'm stressing those two is that I think the hardest part of implementation, there's been the state regulations that require an awful lot of work for the SOTAs to help facilitate change and waivers and all that. And OTPs had to change policies. But changing mindsets, I think, has been one of the most difficult parts. And those two factors that you mentioned are directly related to mindset changes. In terms of, for context, in terms of the regulations, excuse me, for those of you who are newer to the field or new to this concept of Part 8 regulation changes, Part 8 started in 2001. It became regulatory. The field itself started experimental design more than 50 years ago, and then operated under that experimental model until 2001 with the implementation of the original Part 8. That original Part 8 retained a significant amount of the experimental design, but it formalized treatment as a resource for people with opioid use disorder. So it was officially kicked off. It designated SAMHSA as having the responsibility for certification and oversight of accreditation. But those standards needed to be modernized. We needed to bring them into the current era, and the goals of the revisions were to improve, to make treatment more livable for patients, to make it more accessible and more personal and more mainstream. So those together would improve care, quality of care, and retention in treatment. Could you go to the next slide? So this is a very frequently presented OTP slide. Where are we in the nation? SAMHSA slide of where we are in terms of OTPs across the nation. There are, as of last Friday, 2,105 programs, OTPs in general, with 134 fixed site medications and 88 mobile units. Those mobile and med unit increases are very significant. When I started here in 2020, there were only 17 mobile units. There weren't med units, fixed site med units, but the DEA made some revisions that made it more possible to establish these. So over 200 combined is pretty significant expansion of access. And Part 8 revisions also made that formal and permanent. So as far as the regulations are concerned. Next slide. Thank you. So I'll review some of the key changes. These were some of the points that we looked at in terms of where progress has been made so far. And so, as I said, the goals were to improve access to treatment. So starting screening, starting enrollment, splitting the medical aspects of enrollment into screening and then full assessment was very significant. There were many areas of the country where people had to wait 30 days before they could see a practitioner because of waiting lists. So having it be possible to enroll someone with screening and then complete the physical was significant. using telehealth for screening. All of these items identified revising the role of the NPs and the PAs, allowing them to do ordering of medication, expanding their scope of practice within Part 8 was very significant, as was being able to use, or we thought it would be more significant. We'll talk about that point in a minute, but being able to use the assessment completed by external practitioners. Reading between the lines, that speaks to if someone is admitted to an emergency room for an overdose reversal, that physical could be used to, we thought that would be used to expedite enrollment in treatment. Next. Improving access of care also came with revising the criteria for admissions, allowing for take homes that were more consistent with where a person was in life and their progress and the practitioner's judgment. Again, validating that expanded services can be provided in mobile and fixed site medication units. All of these key changes together, the telehealth and take homes together made treatment more accessible. It reduced transportation burdens and the need to show up every single day. Shared decision making improved the sense of trust and improved retention and care as well. All of these revisions, if you could go to the next slide, these revisions helped with improving the flexibility of care at the federal level, but states and OTPs are still needed to implement those changes and operationalize them. Where the rubber hits the road is really dependent on the OTPs and the states since the implementation began. So where states allow practitioners, NPs and PAs to practice expands treatment. Similarly, at the OTP level, more discretion and more use of clinical judgment then requires more documentation. So when OTPs operationalize or improve, revise, standardize their policies and procedures for documentation or have EHR templates, for example, all of those help to operationalize and justify the rationale for decision making. So we wanted to take a look at where everything stands right now. Well, at that time, so we SAMHSA engaged the Center for Financing Reform and Innovation, that we call CFRI, to better understand how the states and OTPs were putting the new regulations into practice, and then identifying what are the facilitators and barriers to adoption, and then set a baseline so that we could then compare in a few more years and see what long-term impacts we gained over time. Next slide. So thanks to ATOD and NASADAD for operationalizing the study. Mark, if you would like to jump in here, I certainly wouldn't mind, but input was gathered. They surveyed and interviewed 46 different SOTAs. 241 OTPs responded to surveys. This data was collected from December of 2024 through February of 25. So this was early and took time to process and summarize and finalize. But it was from that initial window, which was right after compliance went into effect. Next slide. So in terms of adoption and implementation, at that point, we are now more than a year past that point, but at that point, 37% of the states had adopted the changes. All of the changes, 85% had adopted more than half of the changes, and 70% of OTPs had adopted more than half of the changes as well. Next. Of those changes, 89% of the states among the SOTAs that reported and were interviewed. Most frequently adopted changes were use of drug testing, shifting the mindset to use drug testing to inform clinical decision making more than using them as a gotcha moment. 80% allowed take home doses in the first week of treatment, and 80% focused on treatment of medical and psychiatric comorbidities. So further integrated the changes that allowed for more facilitated integration of treatment were among the most frequently adopted. Among the OTPs, eliminating the 1-year admissions requirement was very well received. Updating the criteria for take home similarly was well implemented. 69% eliminated the requirement of 2 documented instances of unsuccessful treatment for adolescents. Next slide. The least frequently adopted changes included screening using audiovisual telehealth, allowing practitioners outside of OTPs to conduct admissions or to use the admissions exams of those practitioners outside of the OTP. Separating medication from counseling was also among the least frequently adopted among states. Among OTPs, the least frequently adopted, that some of which correlates to the state changes, allowing practitioners external to the OTPs to conduct the admissions exam or using those exams, treating other medical and psychiatric comorbidities in the OTPs, and using medication units as an extension to deliver methadone services. So a lot of the increase in use of medication units has been since the compliance went into effect, but this again was at the time an early study. Next slide. Feedback from the states and the OTPs were immediately patient retention improvement, stabilization of existing patients through take homes, and a more patient-centered approach. There was a lot of appreciation expressed about that. Increased inpatient admissions overall, and overall increased access to care, significant improvements in making it easier to get to treatment and to use treatment. Next slide. Okay, so among the key challenges that emerged were, I think we missed one. There you go. Didn't, okay. Challenges, you can stay on challenges. The challenges to implementation were the items that were most significantly difficult to implement for people and caused other challenges for the OTPs and patients were differences among states in terms of scope of practice of nurse practitioners and physician assistants or physician associates. The differences in the state and federal rules, the differences in alignment. There were many states where the SOTAs ended up creating waiver processes within the states or for the OTPs in the states until the rules of the respective state could be revised. And then financial and reimbursement barriers came up often as a problem because of the potential impact of take homes on the reimbursement models, the change in take home reimbursement levels. Next slide. So in what this leaves us with is a couple of opportunities, and the regulation changes and the study both give us the opportunities to take advantage of the expanded practitioner roles where that's allowed, adjusting our business model. This goes back to patient-centered hours that Mark had mentioned, even if there are only a handful of patients available on a Saturday or who need to be able to pick up medication on a Saturday, counseling can still be offered on a Saturday, which would balance the business model, for example. But also expanding partnership, the changes of the rules facilitated collaboration significantly with jails and prisons, skilled nursing facilities, residential programs, and other sites, basically enabling OTPs to develop satellites, and that in turn expanded the reach and the capacity of the programs. And there is still opportunity to reconsider funding and payment strategies, making sure that fee for service or unbundled rates where possible, looking into potentially diversifying funding streams still remains an opportunity for our system of care. Next. So, in conclusion, the preliminary assessment or implementation study shows that it represented a major regulatory shift. It was aimed to expand access through more patient-centered approaches. Some states continue to work on aligning their regulations to allow for the benefits of the revisions and the gains that could be accrued there. Financing strongly impacts implementation. There's a chance that it might discourage more flexible care approaches. And now we have some more resources. Our federal guidelines have been reposted and are available at the location identified. I think these slides will be available and could be linked directly from there. And we still have technical training and specifically for the opioid treatment programs, technical assistance and support services are available. They've been providing training across the country on Part 8 and can be reached through this website also. And I believe that's it, but next slide. Thank you all for your participation, and I think we go next to Jessica Jennings.
We do, and thank you, Patty. Again, since ATOD participated in that, and Angelina was particularly important in this in gathering the data. So we started collecting this right before Christmas in 2024, and collecting anything from anybody around Christmas is not so simple because mostly people are thinking about food and pies and all sorts of stuff. But we did it just the same. And it was instructive. As Patty said, you know, these things are a point in time collection. So when we are collecting the data, it's really to create a baseline. And then this follows over the years because dealing with federal and state regulations is a long-term issue. And since I've been involved in this work for such a long period of time, that I can tell you that you have to maintain a very long-term framework. And as was mentioned, the problem here is still the financing. I would suggest that if the state Medicaid had better financing support, there would be more mobile vans and more medication units affiliated with the OTPs. Also, the expansion that Patty talked about, and you saw that in the map with more than 2,100 OTPs operating, and a major expansion in the mobile vans and medication units is actually contributing to the decrease in opioid-related mortality. I mean, there's a direct connection. As treatment access increases, you have a decrease in opioid-related mortality. And I have to say, this comes from both publicly funded and privately financed sectors. You cannot make the separation. And all of those 2,100 programs, both proprietary or for-profit and non-for-profit, all have to follow the same regulations. There is no sort of discriminatory aspect. Everybody has to follow the same regulations. And this is important conceptually for people to really understand. So there are a lot of issues and criticisms that naturally come to surface, and that's not strange for the OTP system. So Patty, thank you again. Again, we're going to hold the questions to the end once all three presenters have had their opportunity. So next is Jessica Jennings from Ohio. And again, I'm grateful for her involvement and the opportunity for her to share how the programs and the state agencies in Ohio have adapted. So Jessica, it is now your court.
Thank you, Mark. Let me get my slides up here and start sharing. Bear with me for just a moment. All right. There we go. All right. Hopefully you guys can see just the presentation. Yes, as Mark said, my name is Jessica Jennings, and I am the Chief Program Officer at the Ohio Department of Behavioral Health. I am also blessed enough in Ohio to work under an administration that is extremely sympathetic and compassionate and passionate about helping the folks that everybody here in this webinar are also passionate about helping. One of the things we always do is we're talking about access to treatment, and this is a wonderful quote from Governor Mike DeWine about access, but he said we can create the opportunity for people with mental illness or addiction to build the skills to lead joyful, meaningful lives. One of the things that stops someone from being able to live up to their full potential is someone who has an addiction that's not being dealt with. One of the things that you will see a common thread throughout our presentations today is that these rule changes have done just that. We've allowed more people to access those services that really do help them. And I'm grateful that these two people on this slide are my bosses. Now, prior to coming to work for the state, which has only been briefly, so I spent the last 5 years of my career at a national OTP provider. So I am blessed to come at this presentation from both a state perspective and a provider perspective. A little bit of background about how Ohio got to where we are. So Ohio OTP rules are found in the Ohio Revised Code. Ohio Revised Code requires a review of Ohio Administrative Code. But Ohio Revised Code does require that we review those administrative code rules every 5 years, which in the spring of 2024, all of the OTP rules came open for review. And all 15 Ohio OTP rule sections were open for review in response to the notice of the proposed rulemaking. And the final rule package did include changes to 9 of those sections. So what did we do? We grabbed a huge group of OTP stakeholders. It was 326 members of direct involvement with active OTP, either direct service, medical providers, our operators, etc. In addition, we got feedback from all of the stakeholder agencies. So my agency, the Department of Behavioral Health, our state medical board, Board of Pharmacy, nursing, Medicaid, Recovery Ohio, which is one of the very first, actually, I think it was the very first thing that Governor DeWine signed into effect when he became governor, which is our overall board providing guidance and recovery initiatives in the state of Ohio, and the governor's office itself. This feedback was obtained ahead of the required rule review process to ensure that we did have, just like ATOD, just like SAMHSA, had a lot of stakeholder support and feedback in those rule revisions. Some key areas of alignment for us, also very similar to what Patty shared federally. OTP staffing requirements specific to the medical directors and program directors. So the ability for mid-levels, the ability to be more flexible on who we allowed as program directors was a huge area of alignment. Medication take-home flexibilities. I would hope to say not surprisingly, but probably surprisingly, that was the increase in medication take-home flexibility was actually something that was very well received. OTP admission criteria, getting rid of that 1-year requirement. OTP counseling requirements. This one is something that we as Ohioans felt very strongly about. There was a lot of discussion that went into, and I'll get into this a little bit further in my presentation. There was a lot of discussion around what language do we keep in code to ensure that counseling still is a requirement, but also to protect against it being held as I'm going to struggle with how it's said in the federal regulations, but that is not held as over someone's head. Their medication isn't held. So the counseling requirement part, toxicology screening requirements, and OTP med unit licensing. I know our SOTA here in Ohio is really big on med units. We've struggled a little bit to get them moving, but we're hopefully really, really close. But the mobile units. So that was really awesome to see that alignment there. And just a little history, brief, Ohio implemented our new OTP rules effective January 31st of 2025. In that calendar year, we did see, this is a fun statistic that Jordan and I kind of went back and forth as to why we think this is, but we saw a 54% increase in exception requests, which we would have thought that with the new federal regulations, we would have seen a decrease, but we did kind of think that this could be attributed to an increase of our programs working more closely with external agencies, be that residential, the SNF population, in carceral settings, other inpatient settings, meaning Ohioans active with an OTP do have, again, greater access to care and are able to maintain their medications while receiving additional services. So hopefully we were right on that. All right, so one of the things in preparation of this presentation that I did was I reached out to not only my past employer, but another staple in the Columbus community in the OTP world, another staple in ATOD. So the information I'm about to share comes from Community Medical Services, specifically just the clinics in Ohio, as well as comp drug statistics from their clinic in Columbus, Ohio. So one of the things I wanted to highlight here are telemed intakes. This was one of the things that was implemented. This is CMS data. One of the things that was implemented at Community Medical Services as soon as we were able to was allowing that screening and H&P upon intake to be done via telehealth. And you can see the steep increase in 2025 of telemed intakes. But then also that graph on the right side of your screen shows there's no difference in retention. So the difference in in-person physicals being done and telehealth physicals being done on intake does not influence retention at all. So that showed them that there is not a greater risk of not doing that in person with a provider on day one, which I think is extremely speaks volumes. Counseling. I know this has been a topic, especially for Mark, when he asked me to present on this data. So I wanted to make sure that we dedicated some time to it. All of this information comes from CompDrug. So key organizational response, transitioning counseling service from a compliance-driven model to a clinically driven model. He said it beautifully. I was talking to their CEO, Dustin, about this, and he said it wonderfully, that he encourages his clinical staff to use their clinical judgment the same way the medical providers are encouraged to use their medical judgment in determining take-home privileges, for example. So when we're talking about what a counseling program it should be looking like with a client, what goes in their treatment plan, he is encouraging his counseling staff to actually use what their education and their training to do that. Emphasizing counselor clinical judgment rather than meeting prescribed counseling frequency requirements, individualized care, and aligning that, like I said, sorry, there's a bullet point on that. Aligning counseling discretion with the medical discretion already exercised by providers regarding dosing decisions and take-home medications. Observed outcomes. I thought these were really neat. Reduction in required clinical counseling hours. So they did see a decrease in actual counseling happening. However, he mentioned that he saw a huge increase in flexibility or a higher utilization of their peer support services. So using the revised regulations to really, I think this really speaks to an individualized treatment plan that if somebody isn't ready for, doesn't want, their needs follow more of a peer support model than a clinical counseling model in the beginning, that they're able to do that and provide that flexibility. So even though they saw a reduction in counseling hours, they saw a higher utilization of peer support services. And like I said, more patient-centered engagement across the continuum of care. Bear with me while I move my little pictures here. Early lessons learned. Patients benefit from having multiple pathways to support. Clinical resources can be allocated more effectively based on acuity and individual treatment goals. And the shift supports the intent of federal modernization efforts by reducing administrative burden while maintaining the quality of care. Patient outcomes. So this on the left is comp drug outcomes. On the right is community medical services outcomes. I'm going to help you because these are very small words. Comp drug saw a 89% increase of less travel time, a 62% increase in more time for employees or more time to work. 58% of their population said they have more time for family. 55% said they have more time for social activities, and 51% had improved mental health. And this is since these federal regulations have been implemented within their clinic. And then outcomes by time and treatment from 2023 to 2025, this is just CMS's Ohio clinics. So unemployment you saw goes from above 60% at admission to below 40% after 1 year. Unstable housing, we do see a big a slight increase there after 1 year or more, but we are still seeing a decrease. Income improves after a year or more. Mood disorders and severe anxiety also decrease after time in treatment. So this really speaks to the importance of keeping somebody retained in treatment, which these federal regulations really do help with. One of the things that when speaking with both agencies, they all said was that supporting technology helped them either fill in some gaps or to help the comfort of their providers or their staff with these new regulations. CompDrug cited their use of a virtual dosing window really helped their providers as well as their patients with feeling more comfortable with additional take-homes. It supports the increased patient autonomy, provides care teams with greater confidence when extending privileges to patients who may not have historically qualified for take-homes. It maintains the meaningful engagement because they're still interacting with somebody, even if it's virtually, every single day. Somebody has to go in and they have to either approve or not approve that virtual dose. So that still lends the patient something to feel connected to the clinic. And it promotes a more individualized, patient-centered approach to treatment. CMS uses a supportive app, and they've seen a 22% increase in direct service hours from January of 2025 to April of 2026, which includes counseling, case management, and peer support services. But it also includes communication through this app with the patient's care team. The patient can interact directly with their counselor, which helps fill in those gaps when a patient may not be able to stay at the clinic, so they're still able to interact with their counselor. And a 22% increase in direct service hours, I think, is a huge number. And a 13 to 15% increase in year-on-year retention with 85% 30-day retention in clients who complete as little as 3 self-monitoring activities in this app. 85% is a huge number. So they know that if they can get folks connected and using this app early, that is the key, that they're going to see a massive jump in retention. Some additional information from other providers The Zeph Center up in Toledo cited that as a result, patients have expressed greater confidence that their clinic is committed to supporting their recovery while recognizing the realities of their daily lives. They have seen a growth in the number of patients reaching higher levels of treatment stability. That is also, I think, speaks absolute volumes. In terms of patient retention, CompDrug has seen their 90-day retention increase by 17% since they implemented the new federal regulations from 65% to 85%. There's another 85% statistic, but their 90-day retention of their patients is 85% now since they've been able to adopt these regulations. And all of these factors, he said, are related to that: the higher starting doses and quickly increasing take homes with the virtual dosing window. Only less than 10% or about 10% of their patient census, I think he stated that, I'm going to misquote the number, so I'm not going to share it. About 10% of their patient census has less than 1 week of take homes, and only 0.8% is on daily. And then this is really important, guys. This is why we're all here, right? What are the patients saying about this? These are actual patients in the state of Ohio that are commenting on what we're doing. One said, I work full-time from 8 to 5:30 every day, and I'd have to use my lunch hour to come down and dose. And I did that for a long time, but this is a much better way to do things. I get to spend more time with my family. I think it's an awesome program. And now I actually get to sit down and enjoy my lunch on a daily basis and get a little rest instead of driving down there and then back to work and try and do that all within an hour. Another patient shared having no car, relying on family for rides, trying to work, take care of myself, a sick pet, and all of that. The changes really make life much more obtainable. Another patient shared, I appreciate the program and the freedom it brings me in my life when it comes to my recovery. And finally, it definitely helps me having more control over when I take my dose, not depending on when I can get a ride, but when I feel I need it, helps me navigate it better. I should also say that Ohio is one of those states that has adopted most of the federal regulations. A couple of the things that we did that are, I guess the biggest thing, speaking to what Mark mentioned in the beginning, is that we still have it in code that clinics have to be open 6 days a week, with the exception of holidays and one weekend day. So that is something that we as a state thought was extremely important and aligned with ATOT on. Yeah, other than that, that's about it. That's that, and the counseling, we kept some different counseling language in there, and then other language that helps our surveyors. But other than that, we are right on board.
Great. Well, thanks very much, Jessica. And I think that if anything, Patty, you should be quite encouraged by this sort of presentation. It corroborates what you've said, but also it demonstrates that the patients have in fact responded. And,
Mm-hmm.
Given the fact that this only in the passage of 2 years, it's remarkable. I mean, keep in mind that when you do any sort of major national change, implementation generally takes 3 to 5 years. So the fact that you're getting such an immediate response within a 24-month period is quite telling. And for those programs or states that are listening to this webinar that are still on the fence about this, I hope that this is moving you away from a questionable position, because there's no question in mind that I know that there are some issues about medication units and mobile medication units. And this is a chance for providers and the accompanying state officials to go talk to your third-party Medicaid reimbursement groups and to share the information and to say, by the way, having these additional units helps decrease opioid-related mortality. It increases access to care, and it's an overall improvement, because the more you can get people into treatment, the better off their lives are, the lives of the communities are. I mean, it's like when someone said, what is the value of having medication-assisted treatment in jails and prisons? And the answer was, because more than 50% of those people who start their treatment during their period of incarceration, upon release, well, they will not go into recidivism and they will survive because they, when they're not in treatment or they don't get a warm handoff, you have a very high mortality rate after the release. So these are all important things. Jessica, thank you. I thought that's very useful information. And so now we go to Jessica Blouse, our last speaker, the soda from Washington State. Again, Jessica's presented in the past, is extremely knowledgeable, and works very closely with our provider colleagues. And I'm grateful for that as well. So Jessica, go right ahead.
Yeah, thank you everyone so much. Again, as Mark said, I'm Jessica Flows. I'm the state's opioid treatment authority here in the wonderful Washington State. Also, I'm really fortunate to work for our state's Medicaid agency. As many of you know, the SOTA position is different from state to state, and I get to help support things at Washington State Medicaid around clinical policy decisions for substance use disorder treatment. But I do, well, first I'm going to start off by saying, if you're thinking, where are Jessica's slides? I do want to let folks know, in case you're putting questions in the chat, there are not slides for me today. I'm going to be talking verbally with you for the next few minutes about Washington State's experience with the rule changes. I will start out by saying our state is one of the states that really heavily leaned into adopting and aligning with all of the federal requirements changes that went into effect for OTPs. We had the opportunity to review things, and honestly, collectively, all of our state regulatory entities, we liked what we saw. So one of the really important steps that our state did is our colleagues at our Washington State Department of Health, who also regulate opiate treatment programs, spent the time to create provider workshops in our state to talk specifically with the opiate treatment programs about the federal rule changes that were going into effect, to see what were providers' thoughts, what did they like, what were they worried about. And another really important thing that we did is our state actually worked with providers collaboratively. And basically, we looked to see when there were state rules on a topic and federal rules on a topic that were either duplicative or maybe completely dissonant. And we actually worked to remove those state rules that we thought were duplicative. You all know, as providers, OTPs are one of the most heavily regulated environments that are out there for a healthcare setting. We wanted to help reduce administrative burden to opiate treatment program providers, again, remove instances of dissonance. And then we also all collaboratively thought we're moving into, again, kind of a high stakes, sometimes highly audited environment, and it would probably be beneficial for all parties to seek alignment with federal requirements that, again, we were supportive of. So again, with the support of our providers, with a lot of feedback from Washington State providers, we did. We greatly changed our state rule set for OTPs and again, tried to remove requirements that were duplicative. So that way OTPs hopefully have a much clearer pathway forward about what regulations they should be following. Another thing that I think is important to mention is in our state, since we've made some of these changes to align state regulations and federal regulations, we have not seen like increased complaints at all from patients or grievances. We're not getting increased like critical incident reports from our OTP providers. In reality, it's been really well received, as we've been hearing throughout this presentation all along, by both providers in our state and the patients that we're all serving together. So again, on that one piece, I would just really encourage other state partners to think about where you can find alignment, because there can be also a lot of benefits to the state and in terms of how you enforcement with regulatory activities with OTPs as well. Now, I'm also going to dive into a couple different examples of where the federal rule changes have really played out in our state in successful ways. Let's start with the changes that allow for more utilization of telehealth, or again, the telehealth-based initiation, audiovisual of initiating folks onto methadone. So in our state, we were very fortunate that we have already, as a state, been very supportive from like a Medicaid payer perspective of the utilization of telehealth for behavioral health. especially in relation to workforce shortage needs that many of our states are dealing with. But again, at this point, it was wonderful to see like state and federal requirements kind of catching up to one another, coming on board, specifically for opiate treatment programs. And in our state, even I'll use a couple patient examples from the last few weeks. We have been able to work with different OTPs in our state in the last few weeks to do some of the following things. There is like a patient who have been initiated onto methadone in a hospital setting, and they are looking to get discharged to a skilled nursing facility. Through the utilization of these federal requirements that allow for telehealth initiation, an OTP provider partner is able to help start someone who's in a medically fragile state to initiate, maintain their methadone, and then be able to connect with them when the patient was discharged from the hospital and then receiving care in the SNF setting. Um, Another example that came up is we had an existing OTP patient fell into a period of instability, ended up getting incarcerated. They had missed a significant amount of dose days. But with, again, the flexibilities that are allowed with the medication initiation, the opiate treatment program provider was able to do a telehealth visit with the individual who was incarcerated to determine like what is the appropriate dose that they could be on in order to essentially restart them on their medication, all the while, again, maintaining a connection that will hopefully continue for the duration of the patient's stay in a carceral facility. So those are just two examples, but again, things that I think are very helpful. And I'll even throw in another thought. I know Dr. Juliana had mentioned that the federal rule changes which allow practitioners external to OTP to conduct admission exams. Even in that one example we had just talked about with partnering, an OTP partnering with a hospital, utilizing staff at the hospital to help support like the H&P, the health and physical evaluation of that OTP to again be able to help someone get initiated and connected to the OTP prior to their discharge. It's so great to have again federal and state rules that align on things like this and just help support patient care and literally meeting people wherever they're at. Another different set of examples we can talk about are some of the federal requirements that went into effect that really promote in opiate treatment programs embracing the spirit of whole person care. We know historically, right, opiate treatment programs have always been able to say, patients, you're welcome here. We have MOUD and methadone for you. But now when patients come in the door, OTPs are better supported in being able to say, in addition to supporting your opiate use disorder and substance use disorder, how else can we make sure that you're healthy overall? So again, having the federal rule set aligning with state requirements has been super helpful from a Medicaid perspective. We had the confidence to finally be able to introduce more payment methodologies and billing guidance and encounter billing guidance specifically for opiate treatment programs to let them know if they want to do infectious disease screening, testing, and treatment on site where they are literally the providers offering those services. Here is a pathway to bill for those services if you would like to do so. We also were able to talk with our OTP providers and hear the feedback around, the comorbidities of many types of infectious diseases and bloodborne pathogens is so profound that providers in our state were supportive of our state actually introducing state-specific rules that do require all OTPs in Washington state to provide either on-site or by referral off-site screening, testing, and treatment for infectious diseases, specifically also calling out HIV, syphilis, TB, hepatitis C. We also partnered with our providers and put into place state rule requirements that require OTPs in our state, again, to offer on-site or off-site vaccinations for like hepatitis A and B for patients is like a preventative measure to prevent, again, other infectious diseases. So in our state, Many of our programs are really leaning into this work. Special call out to all of our amazing tribally owned and operated OTP providers and some of our OTPs that are owned and operated by public health departments in our state, because they're really leading the way. And again, just knowing that these things are allowable and supported and encouraged has made a huge difference, because then it also allows providers in our state to work on capacity building. Because while everyone can meet state requirements around referring patients out, when patients again are able to get care that they need and a place that they trust that will offer them, non-stigmatized care, a lot of our OTPs, again, are working on capacity building to see how they can actually work towards offering this care in-house. And that also diversifies potentially income streams long term. So again, just another really cool way that the new federal rules and state rules aligning have been successful and hopefully leading to even better outcomes moving forward. Another specific topic we can talk about is, again, how we're treating emerging populations. There were a lot of federal rule changes around, making it much clearer that youth MOUD treatment is accessible in OTP settings. So again, being able to align state rules, making sure it's very clear to all OTPs, if you are willing and able, you are supported in serving youth and their parents and guardians in a community and getting them the care that they need. And it's also allowed us as a state to look at different things. We were able to then start looking more at our state Medicaid policies and ensuring there are things like not cumbersome, like prior authorizations that might have been in place specifically for like youth specific care for MOUD in all settings really in our state, as well as in OTPs. Also, it's freed up providers to be able to actually dig into what does it mean to offer this type of care for youth populations. So being able to move from a point of, oh, we're so worried as a provider if we're even allowed to serve this person who's in need, to being able to think about, well, how do we determine like the appropriate doses for a youth patient? How do we determine how to offer developmentally appropriate counseling services or partnering maybe with like other youth providers in the community where they could do the counseling, but we can offer again the medication. And then how to like look at dosing hours when there are youth individuals who might be needing again access to buprenorphine or methadone. But youth have to go to school. They have to, do other things. They might be working. Can we use the chain of custody things to allow like guardians to help safely secure medications in the home? Can we look at OTPs to offer more buprenorphine, even specific access? I know for many and external parties, like methadone for youth is still a thought that like seems to have, again, a lot of just misunderstanding and fear for external groups. But again, OTPs really are subject matter expert treatment providers in their community on addiction medicine treatment. And again, even if OTP is able to offer buprenorphine for youth, you might be the only OTP in your community that is doing that. And again, special shout out to the Acadia Healthcare group in Washington State, who actually, I believe, is doing a pilot. One of the first for Acadia Healthcare as a system in the nation to develop full-on policy and procedures specifically for what it means to serve youth and how to develop staff training for that. So again, such a great thing that there are now federal rules that have just made it abundantly clear what is possible and really, again, thinking like opening the door to thinking outside of the box of traditional streams of business. And then again, how OTPs can continue to support other partners in the community. Another thing that I think is helpful to highlight is, these rule changes that have gone into effect. We all are very aware of them. Again, OTPs are hyper-regulated environments. All the state officials on these calls are very aware, of course, of OTPs. External healthcare systems don't necessarily know about these changes that have gone into effect. Our state has really leaned into, utilizing its SOTA office to basically do like a virtual roadshow where we are trying to present to hospital associations, carceral facility providers, provider associations representing post-acute care facilities like SNFs and ELFs to talk about, like, hey, did you know there are a bunch of changes to the rules for OTPs? And if you have historically struggled with getting patients into treatment, things might be easier. Really getting a chance to highlight the increased ability for take homes, telling a SNF provider, if you admit this patient on methadone, they won't necessarily have to be brought physically to the OTP every single day. Makes a huge difference. Talking about the telehealth initiations, the ability to, like, again, coordinate with external providers. So the OTP provider and external provider can, sometimes coordinate on developing patient's care. I just really want to encourage folks that everyone on this call knows that methadone patients specifically are still dealing with a lot of patient rights issues. They're still in a lot of places being widely discriminated against. And we're making tremendous progress as a nation in this area. But again, combating stigma, myth busting, just providing a general raising of consciousness that, again, this isn't necessarily like the opiate treatment program of years gone by. And while I know none of us would probably say an OTP necessarily is a super low barrier treatment environment, accessibility for treatment is more present than ever before. And ensuring that providers know it is an option and that if methadone really is the best medication choice for someone, being able to get that care is so important. And making sure folks who are still maybe even also in active drug use know, again, you can go to an OTP and you can get the care you need for the whole person. And again, we're more able to meet folks where they're at. And it's also allowed us to really dig into this whole patient rights topic in our state and do things like partnering with the state agencies that regulate different healthcare setting types to try and introduce state rules that say MOUD patients have to be served in different settings, partnering with our state's Attorney General's Office, Civil Rights Division, and even our partners at the Federal Department of Justice to investigate providers who are discriminating against patients. And then again, working here at the Medicaid state agency to try and create more language prohibiting like MOUD patient discrimination in the provider network. All of that is only possible because, again, now treatment is more accessible for folks as they go on to secondary parts of the healthcare system. I could go, on and on. Our state has 16 mobile medication units, the most in the country. And again, with some of the federal requirements, we've been able to create like extensive technical assistance materials for OTP providers in our state, working with providers who have already established MMUs to create FAQs for the other providers who are still evaluating. Is this a book of business we want to get into or not? We have been able to also promote and advocate where appropriate for use of things like opiate settlement dollars and general state funds to help support both the creation and supplemental funding of medication units in our state. Right, we've been able to look at the changes of the year-long requirements for the opiate use disorder diagnosis that changed and went into effect to really help make sure state rules, again, are in alignment with supporting a medication first initiation opportunity in OTPs, because as we know, with like fentanyl, unfortunately, folks are developing moderate and severe OUD faster than ever before. And then even outside of the box things you wouldn't think of, like the expanded take-home privileges really have allowed for downstream impacts of our state to be able to evaluate, along with mobile medication unit expansion and fixed site medication unit expansion. Like there are costs that many states pay for like non-emergency medication transportation for Medicaid, where Medicaid patients are supported and like literally getting transported to the OTP. But when folks are able to get clinically appropriate, take-home doses that still support their health and wellness, and we're not needing to expand certain state resources when it's not medically necessary, that really does help in state environments. I'm going to give one example. Even just yesterday, our SOTA team got approached by our state's non-emergency Medicaid transportation group to say there's one OTP patient in our state since 2022 who has been having around $100,000 a year in non-emergency medication transport costs to Medicaid to get transported daily to an OTP. But with the federal rules, this does allow our team now an opportunity to reach out to that OTP provider and have a conversation around, potentially why it may be possible that someone who's been in treatment since 2022 is still going daily for treatments. And there might be good reasons why, if someone's unstable, that's still happening. But again, having this framework allows for conversations that don't have to be putative because it does allow us all a common base of understanding of, again, now what is possible. And I think last thing I will say is, again, representing a state Medicaid agency, we also do need to look at, as states, on how we can provide accurate payments to OTP providers that really is going to fully support the wide array of services that people can now receive in OTPs. Try to offer more flexibilities to account for the individualized care that folks are having. And then also thinking about the differences in episodes of care, where some folks who are newer to treatment are again struggling with periods of instability and relapse might need really more intensive services. But then there are also lots of patients, because this is evidence-based treatment, right? We're doing amazing, doing really well, and are on like a maintenance form of therapy for years. And how do we, as our payment systems adjust, move away from a one-size-fit-all payment model to thinking and working with providers to ensure that we can try and get to a payment future where, again, we can support our OTPs in doing the business that they need to do. Because, again, we need our OTP partners, as we've been talking about. You are all so important to combating our state and our nation's opiate and overdose crisis. So I am going to pause there, but I really hope some of this positive news will sink in different areas. It really has been overwhelmingly positively received here, and I really do feel like finding alignment has benefits for patients, providers, and even state officials. Thank you.
Thank you, Jessica. No, very helpful. And point Jessica's made, which doesn't get discussed often, but I'd like to underscore it, is the importance of SOTAs and state officials who are much more connected to our system to explain to the other healthcare systems in their functioning states that this is what's going on. It's a major change in access to care because not everybody understands it. And I have heard from providers like Dustin in Ohio and other providers that have said that some other state groups are now aware that changes have been made and access to care is better. So now we're going to take the remaining 15 minutes to answer as many questions as we can. For those we don't get to, I will send them to the appropriate presenter so they can respond. So the first question is about counseling, and I will read from portions of the question, which is, they got the idea that counseling must still be offered to the patients under the SAMHSA regulations. But the question then becomes, so if the OTPs are required to offer counseling, but patients are not required to accept those services, how do the programs negotiate through that? So we could start with Patty and go to the other speakers, but that's basically an interesting issue, and that's where some of the confusion comes in. So, okay, counseling services have to be provided, but suppose the patients say, well, I don't want those services. What does the program do?
So this goes back full circle, Mark, to what you were saying in the beginning about the reason that counseling is required, and that it's counseling, the OTPs are required to offer the counseling. There is one line that says, though, that patient refusal of counseling cannot be used against them to withhold medication. Specifically, that it's a very short sentence. Most of the time in the regulations, counseling is stressed as the OTPs needing to require it, and in different ways. It's defined in the under the physical and behavioral health counseling requirement. It's restated in the body of the required services. Boy, this is a repetition of required, but it's also presented in terms of the requirement for providing HIV, STD, STI prevention, education, and treatment. The bottom line is that by the time people get to an opioid treatment program, they've experienced a lot of disruption in their lives, whether it's disruption that caused or led them into OUD, or whether it's resulting from their OUD. There's family disruption, there's employment, or education issues, legal issues. There are many different things that lead to and result from opioid use disorder. And so it requires the answer to the question is that in order to support somebody best in recovery, really do need to take the whole person into consideration. Counseling has many different aspects to it, but a full assessment will invariably identify some areas where support can be provided, whether it's provided directly or indirectly. There still is a need for some education of patients around what's available to them and what can be done. So can't withhold medication if the person doesn't want to participate in counseling, but the programs are still required to, in many different ways, are required to provide the service.
Okay, I appreciate the clarification. Given the range of questions, we're going to go now to Jessica from Ohio. Jessica, you've got several questions put to you, so I'm going to give them all to you at once.
Oh boy.
First, well, there are many, but I'm going to give you these, what I perceive some more critical ones, which is, and this is a little bit more, I go from the simpler to the more challenging. How do you describe the virtual dosing window? Remember, not everybody is familiar with that technology. Second question is, how do you actually do the telehealth physical? Because the questioner is saying, wait a minute, I thought that physicals have to be done in person. And then the third, slightly more complicated question, since it's comparatively new, is how is it that we expand OTP service delivery with new Medicaid work requirements that are being talked about? So those are the three.
That third one's a doozy. Okay.
That's why I saved it for last.
Yeah, thanks. So virtual dosing window is a really, really cool technology that allows and it's fairly simple. So it requires a smartphone with a camera that most providers or the tech that supports the virtual dosing window can help provide. But a person films themselves taking their dose. There's a specific label on that dose that they scan, that they show the picture with their name, their dose amount, that date. They then film themselves taking the dose. There are certain components to it where I believe, and if I'm misquoting, I know I'm going to get messages. They have to speak afterwards. They have to show that the bottle is empty, that sort of thing. And then staff at the physical OTP are responsible, and it's typically nurses. They are responsible for reviewing those videos and then either accepting or rejecting that dose. Certain folks, after too many rejections, are, maybe pulled off or taken out of the virtual dosing program. so that they do have to end up presenting to the clinic more often. However, the vast majority of these folks are extremely successful. This can lend, like I mentioned in the presentation, it does allow providers to feel more comfortable with providing extended take homes that they normally wouldn't have been eligible for, because they know it's still being observed. They know that they're still seeing the patient. Somebody from the clinic is still interacting with the patient, even if not live stream. But it also, can prove patient stability. So, if somebody is successful long-term on a virtual dosing window, then they can go to non-virtual dosing, that sort of thing. So I hope that answers the question. Those are just some really quick tidbits about that technology that I think is really, really neat. When I first heard about this, it was not at the ATOD conference. I think it was at one of the symposiums, but I was immediately drawn in and thought it was really cool. And it really does complement the new federal regulations in a great way, especially with providers and or states that may not be as comfortable, especially with the extended take home portion of that. Now, getting to the second question about the physical, I think I had misquoted I think I misspoke myself. That gives, and please, Patty, help me if I'm incorrect here. If in-person physical does still need to be done, it's just within a longer time frame. Is that correct?
So the actual physical part needs to be done within 14 days. If the screening can be done via telehealth, but at some point there needs to be hands-on.
Yes. So I did misspeak. I misspoke. I apologize. So to answer that question, yes, you do still have to have an in-person physical. I was speaking more about the telehealth inductions. So that screening portion where we can make sure that a patient presenting to a clinic on day one can get medicated on day one, regardless of whether or not there's a physician or a mid-level present in person. So I apologize for that. Now, I'm going to have to end up making a phone call to one of my previous coworkers after this call regarding that third question. So work requirements. There are a lot of exceptions to these that I believe will come in extremely handy to our OTP friends, especially regarding the work requirements. I know there are certain parts of this that contradict what we see in exceptions, but from my understanding, okay, this is not, I am not a government official. I am not somebody that is an expert in this. I am not somebody that is an expert in the actual legislation part of this. From my understanding, the exceptions to the work requirements will, hopefully, I guess we can all cross our fingers here, will cover OTP patients. Those that are engaged in an OTP, receiving ongoing services for their diagnosed substance use disorder, will likely be an exception to those work requirements. So they will not have to do that. I know, like I said, I know there's a lot of conflicting information out there, but as far as I know, all of the lobbying, all of the advocacy that happened prior to that bill getting signed was successful in that thank you, Jessica, dear goodness, I feel like you're saving me from my life raft here. But I do feel like there's a lot of protections in place for the folks that are in treatment with the OTP providers.
And to let you know, Jessica, what ATOD is going to do in about a week or so is issue some guidance on Medicaid work requirements. As you said, this is rapidly evolving. You have CMS releasing rules on this, and we will be providing some guidance about this issues. And I'm sure that programs are going to need technical assistance in dealing with this, because this is a complex area. Now to Jessica from Washington State. There are two questions, so I'll give them to you also at the same time. First is, are there any suggestions on use of security for the use of mobile vans, since you've got 17 of them in your state, to reduce the risk of vandalism? That's the first question. The second is Executive Order 14321 concerning involuntary civil commitment for persons without access to MAT in your jurisdictions, anything that you may know. So I know this is a pretty specific question. So those are for you.
Sure. You're right. I think in our state specific rules don't necessarily get into too much around security requirements for the medication unit specifically. Um, a lot of times the providers in our state, of course, are closely aligned with other state regulatory entities in our state's pharmacy commission, as well as, of course, the DEA, our federal partners there. But many of our OTPs do have a security guard that they employ, and that has historically been a part of their practice. And I know in the past we have also paid for some of the state funded mobile sites. We use some cost assumptions around potentially giving enough money to a program that would help pay for like a driver slash security guard type position. So again, we did take into account that many of our programs do that, but from a state rule perspective, we just don't necessarily get into that, and we allow the flexibility though. If an OTP provider would like to hire for security, they're absolutely able to do that. And then the second question around involuntary treatment and commitments, I will say we have had a number of patient cases in our state where there is an existing OTP patient who also had a mental health diagnosis, kind of decompensated, ended up being involuntarily detained. And there have actually been a few situations where we have been able, through promoting the use of the 72-hour rule, to potentially dose someone initially while we're getting the OTP to be able to dose someone. We have been able to get an exception in place to allow take-home doses of medicine to go for someone while they're detained. There are some other interesting intersections, though, with patient consent for treatment that do arrive in instances when someone is detained and they may or may not have legal capacity to give consent to different things, which is a really interesting intersection. But I do think in this, it kind of goes back to this outside of the box thinking. There are all kinds of settings where an OTP patient may end up, whether they're incarcerated, they're in a car accident and they end up at the hospital and they need to go to, again, a rehab facility. They end up in a mental health or substance use inpatient facility, and folks need care. And just wanting to state again, like that, those abilities now to partner with external providers to help evaluate physically how a patient is doing. Many of these other settings do have prescribing providers, LPN, RN, nursing staff who can help, gather information like vitals and assess, and then the use of telehealth to coordinate that care with an OTP. More is possible, but then the intersection with involuntary treatment, I will also say, like, we, like probably all states, are still trying to think about this specific intersection. And so it is definitely a complicated topic. But if anyone in Washington has questions about that specifically, you can always reach out to your SOTA. And also, maybe I'll just say, with some of the questions around Medicaid, I do want to just encourage all parties that, like, your state's Medicaid office is likely having public facing meetings. They likely have a website around HR1 impacts. And I would just encourage folks to look for that website, get on those listservs, attend those state Medicaid settings, because they may be the best place to get updates. And then for any of my SOTA colleagues on the call, I know we're not all in a Medicaid agency, but as the SOTA, you are going to be asked about questions like this, and having the ability to connect with your colleagues in state to have answers and know where to point people, and knowing that's going to go a long way with helping to reduce anxieties and then providing accurate information. So thanks.
Well, and that's going to be the last word on this. And I'll just close that. Yes, almost always by providing clear information, you reduce anxiety. And to be sure, given what we deal with at the association daily, there's lots of anxiety, not just in general, but even specifically around our system. So that's part of why we do these webinars. Once again, I'm grateful for our three presenters for their willingness to share this information. I know there are always lots of approvals to go through to actually appear. I'm aware of that. I'm grateful to our partners at the Opioid Response Network for their support in getting these things done. And remember, you've got that survey link. Please respond to that because that helps guide us for the future. And we'll certainly, through Angelina, notify people once the recording for this session becomes available. And if you have a request for certificates of attendance, you send them to the address listed here. Angelina, who's very helpful in coordinating all of these webinars, will certainly respond to that. And so from my point of view, thank you very much for joining us. I really do hope this has been helpful. Again, we really do try to provide guidance to our system, and we've done that since our founding in 1984. And I've had the privilege of dealing with all of that since 1984, which is why I am now a much older creature that you see before you. So with that, I thank you again. I hope that you enjoy the rest of your day, most especially for your work in our field. You really do save lives, and you do improve the health of people. And so, as I said at the beginning, for questions that were not answered during this webinar, I will send them to the appropriate people so you will get your answers. So thanks again, and we'll let you know when we do our next webinars, which should be around September, following the summer. So thanks again. Everybody be well. You take care now.